So today we are talking about chronic shoulder pain, and we will start the lecture with the basics. So chronic conditions of shoulder. So the first thing to note is to know what chronic means. So acute is something that happens suddenly, and chronic is something that is progressive, is happening for a long duration of time, is with you for a very long period of time, and is progressing in nature. So people say that acute conditions are severely painful, and chronic conditions are not very painful, mainly because the body has adapted to constant stimulus of pain, and thus the intensity of pain that is felt is relatively less, but there are conflicting opinions on this. But the overall effect of chronic conditions is worse than acute conditions. So because of some acute trauma to the shoulder, that is not as dangerous or bad for the shoulder as chronic conditions are, because like arthritis, it's irreversible. So arthritis is not something that you can reverse. You can slow down the process of degeneration, but you cannot reverse it. So that's a little bit about chronic conditions. So chronic shoulder conditions we will discuss in this entire lecture. All the conditions that we're discussing are chronic in nature. So the first one is the AC glenohumeral joint arthritis. So arthritis, or the degenerative joint disease, or osteoarthritis, is the decrease in the bone mineral density of the bone. What happens is that because osteoarthritis, so it's an inflammation of the bone. Itis, with any term, is indicating that it's an inflammation. It's so this inflammation of the AC joint and the glenohumeral joint. We will see how that appears on the radiographs. So the second thing is shoulder impingement. We will see how shoulder can be impinged. Shoulder impingement is basically two structures are pinching the structures that are passing beneath them. So bones obviously are the humerus, and the glenoid are making the joint, and the surface between the acromioclavicular joint and the glenohumeral joint is a very small surface, and multiple tendons are passing through it to finally attach to the greater tubercle of the humerus. So especially the shoulder impingement affects the supraspinatus tendon, or the subscapularis tendon, which is present superior just below the acromioclavicular joints, more specifically below the acromion. So that is a little bit about shoulder impingement. So this shoulder impingement, let's go back to it. So shoulder impingement is actually, we're talking about this in chronic terms. So this is happening progressively in a long duration of time. So constant stress on the tendons that leads to impingement and their calcification or rupture. We will talk about that. So obviously, what results in rupture is actually impingement. So impingement for a long duration of time actually results in the tears or ruptures of the tendons. So chronic rotator cuff tears, we will see how they appear on the radiographs, but the main reason mostly for the rupture of tendons is impingement, talking about the shoulder joint. So then we will talk about the avascular necrosis of the humeral head. So humerus, so the bone also requires nutrients and blood supply, just like any other tissue of the body. So if the bone is not being supplied sufficient amount of blood and nutrients, there is progressive death or progressive degeneration of the bone, and ultimately death of the bone. So what happens, there are 5 stages of necrosis, and we will discuss the details of all those stages later on in the lecture. So then lastly, we will talk about the bone tumors and the soft tissue masses. We will see how they appear on the radiographs. So first, like we said, we will discuss the shoulder impingement. So shoulder impingement is because of two anatomical structures which are, because of less distance between them, the structures passing between or below them are impinged or pinched, and thus there is resultant inflammation, calcification, or rupture of these structures that are passing. So this is the subacromial space. So subacromial means sub means below, and acromion is this structure. So this is the scapula, this is the acromion, the clavicle, and the humeral head and the humeral shaft. So this space right here is the subacromial space, and the subacromial space, if this space is lessened or is not enough for the supraspinatus tendon or the subscapularis tendon, which is passing from here and is attaching to this greater tubercle of humerus. So this is where the subscapularis tendon is. This is the root of the subscapularis tendon. So if it is impinged between this space because of the narrowness here, then we call it subacromial impingement. The bursas here can also be impinged. There is subacromial bursa here. The impingement, the resultant impingement of the bursa will in turn impinge the tendon which is passing beneath it. So bursa will be impinged, the tendons will be impinged. All the rotator cuff tendons are attached to this greater tubercle. So the resultant impingement can be of any of those tendons. So that is subacromial impingement. Then we have rotator cuff impingement. So subacromial impingement is only the structures which are passing beneath the acromion, right? So rotator cuff impingement is all of these structures which are present in greater, which are inserted here on greater tubercle of humerus are supposedly passing through this surface, and the pectoralis minor is here. So the impingement, which can be the subacromial impingement, can cause the rotator cuff impingement. There can be other causes of rotator cuff impingement. So what happens is this right here is showing calcification of subacromial because of subacromial impingement, actually, because this is the acromion and the clavicle. So because of subacromial impingement, there is rotator cuff impingement. The subacromial bursa here is impinged. Then due to this pressure, this increased pressure, the subscapularis tendon, which, like I said, is attached to this greater tubercle here and also this greater tubercle here. So this is the root of the subscapularis muscle, and tendon is attached here. So this is actually the calcification of that tendon. So this shows the rotator cuff impingement over. So the stress causes tendinitis calci, we call it. So that is calcification of the tendon, which is due to inflammation or impingement of the structures which are present above or below the tendon. So this is due to the increased stress and constant impingement of the tendon, which results in calcification or the accumulation of calcium in the tendon. So what happens then is that due to this calcification, the stretch or the stretching capacity or capability of the tendon is reduced, and then it is more susceptible to rupture. So if something is stiff, the elasticity actually decreases and it's more prone to breakage, right? So that same principle applies here. So the more stiff the tendon is, the easily it can be ruptured. So calcification thus is not good for tendons. Yes, calcification, some might say that it will increase the actual strength of the tendon. Yes, but the elasticity is what is required from the tendon to maintain its proper functioning. So if the calcification of the tendon is present, then the rupture of that tendon is requires less force or is easy comparatively. So this is calcified subscapularis tendon here. So now we will talk about arthritis. Here we're going to talk about osteoarthritis and not the other types of arthritis. So osteoarthritis, there are a couple of characteristics of osteoarthritis. So osteoarthritis involves many joints of the body. It can involve the spine. It can involve the small joints of fingers and thumb. It can involve the shoulder joint. It can involve the knee. Knees are very susceptible to osteoarthritis. Every other women is post-menopause is susceptible to the development of osteoarthritis. So this is actually a radiograph of the shoulder, which is showing the degenerative changes or the degenerative joint disease of shoulder joints. So what happens is there are some characteristics of osteoarthritis. The first is there is joint space narrowing. There can be bony spurs. The presence of bony spurs, those are very sharp-ended bone formation in the tendons. Like I said, the tendon, the bone formation or the calcification of tendon is never good. So they can be sharp and thus impinge the tendon further. So bony spurs, joint space narrowing. Then there is the degeneration of cartilage. So all of the sclerosis, so we will talk about sclerosis in detail, how it happens, and all the osteoblastic and osteoclastic activity associated with sclerosis. So all of these are characteristics of arthritis. So what's visible here is a generalized decrease in bone mineral density, or there is the weakening of bone. So obviously this is the reduction of the joint space is visible here. So no cartilage left, bone grinding on bone. So that is friction. Basically, friction is never good for the joint. It will further damage the joint. So if there is cartilage, the frictional, the entire friction is reduced. So if there is reduction in the cartilage, or there is narrowness or narrowing of the joint space, then the resultant bones will experience friction on movement, which will damage the joint. So due to that friction, there is increased stress on the tendons which are attached. There is increased tension on the bursas in the close proximity to the joint capsule. So bony spurs or osteophyte formation is common after there is joint space narrowing because of friction and all the other factors that we just discussed, because the tendons are continuously in stress. So there is increased calcium in the tendons, which results in calcification of those tendons. They can then develop into osteophytes, or the bone itself can, the fragments of bone can detach from the parent bone and form the osteophytes. There are multiple reasons. So now let's talk about the acromioclavicular joint. So the acromioclavicular joint is the joint between the clavicle here and the acromion process of the scapula. So this is the scapula right here, and this is the acromion and clavicle. There's the humeral head, the glenoid cavity right here, and this is the acromioclavicular joint. So there is some superior translation of the humerus here, but we will not talk about that because this is obviously there is impingement here. But let's focus on acromioclavicular joint for a minute. So there we can see there is obvious sclerosis here, joint space narrowing here. The capsular, these seem inflamed because these are not supposed to be visible on radiograph, right? So these structures, the capsule, ligaments or tendons that are attached here, so they shouldn't be visible here unless there is some calcification or these factors. So this is increased sclerosis. There is generalized weakening of the bone here that is visible. So there is sclerosis as well, there is joint space narrowing as well. So this is acromioclavicular osteoarthritis or degenerative joint disease. So now we will talk about glenohumeral joint osteoarthritis as well. So for this, let's just discuss here and not talk about this. We talked about this before, but there is obvious deformity of this joint here. But let's focus here. So there is increased sclerosis. So sclerosis is basically the increased osteum activity. There is initially increased osteoblastic activity where there is any degeneration, and then there is increased hyperaccelerated osteoclastic activity. Osteoblastic activity means bone formation activity. Osteoclastic activity means bone dissolution activity, or the bone is dissolving by the osteoclast. They eat the bone. Okay, so osteoclastic activity is preceded by the osteoblastic activity. So first there is more increase in osteoblastic activity, which is bone forming. So the bone forming activity in close to the joint surfaces is also known as sclerosis. So the sclerosis is visible here, and of both the joint surfaces, the glenoid and the humeral head. So obviously there is joint space narrowing. What happens with joint space narrowing is there is increased friction, and obviously there is loss of the joint cartilage, which is responsible for the entire maintaining the space between the structures. So increased friction, then there is increased degeneration. So it's a cycle. So that is why we say that osteoarthritis is a progressive degenerative disease, which we can slow it down, but we cannot reverse it. We cannot put an end to it. So this happens in a long progressing period of time. So that is why it's called chronic condition. So mostly seen with old age and increased use or overuse of some joints. And also we can say that maluse or improper use or abnormal use of some joints also results in osteoarthritis. Also, the calcium deposition depends upon the gender. So gender differences, obviously, menopause. After menopause, the women are more susceptible to osteoarthritis because the entire protective mechanism of the hormonal protective mechanism has disrupted. So those are many of the reasons why people are why osteoarthritis is very much common in our community or society. So then we are going to talk about rotator cuff tear. So rotator cuff tear is the attachment. Let's talk about the attachment. All the 4 rotator cuff muscles are attached to this structure right here, the tubercle of the greater tubercle of the humeral head. So here. So this right here, as we can see, is no space between the clavicle. The acromion is hardly visible. So, and this is the glenoid cavity. So like I said before, what happens is that the rotator cuff muscles are keeping my, let's just talk about me. So the rotator cuff muscles are actually making sure that the deltoid muscle doesn't push or doesn't pull the entire shaft superiorly. They're keeping in check, and they are maintaining my humeral head in my shaft, pulling the humeral head from different directions. So there are supraspinatus and infraspinatus present here, the subscapularis present here, and the teres minor present here. So they are keeping my humeral head in the glenoid cavity. They're keeping the check, they're keeping the deltoid pull in check. So that is the basic function of the rotator cuff. besides the abduction and all the movement functions. So they're keeping the deltoid pull in check. So what happens with rotator cuff tear is there is biomechanical imbalance. So there is an imbalance between the biomechanics. So there is superior translation of the humerus on the glenoid or towards the clavicle or towards the head of an individual. So this is because of the increase in the deltoid pull, and because obviously there is some tendon rupture. So this is what is visible here. There is increased translation. There is excessive increased translation of the humerus superiorly in a diagonal direction, because obviously the deltoid is pulling it right here. So the function of deltoid is to internally rotate and flex the arm, but that's the direction in which the deltoid is pulling. So there is a diagonal pull of the humerus in this direction that is visible in this radiograph as well. So then we have proximal bicep tendon tear. So proximal bicep tendon tear, mostly the tendon tears of bicep are involving the long head. So what is the attachment site of long head of bicep tendon? We should know that to diagnose this. So anatomy is very important. You should know where muscles attach. You should know where bursas are. You should know what bone is where and what the orientation of bone is to actually know what view we are talking about and what bone and bursas and ligaments are visible. So we're going to neglect everything else and just talk about the bicep tendon. So bicep tendon, long head of bicep, actually moves through the bicipital groove and attaches to the superior surface of the labrum. Labrum is the structure that is deepening the glenoid cavity, because the glenoid cavity, as visible here, so see, the glenoid cavity is not very deepened and the humeral head is very like convex. So it is extremely convex, but the glenoid cavity is not comparatively or incongruent to this surface. It's not very concave. It is slightly concave, we can say. So this structure right here, this dark hyper intense structure is the labrum. So this So the hypo intense structure here is the labrum. Hypo means black. So this is darker. Obviously the bone will be lighter or hyper. So the superior surface of labrum is the attachment site of the long head of bicep tendon, which is the most commonly ruptured bicep tendon among the two. There are two heads, the short head and the long head of bicep. So the long head attaches to the superior labrum, and this, we can see there is a retraction of this portion of the bicep tendon, and the rest of the bicep, and there is entire space here. So this space is empty, and this is where the long head of bicep is the ruptured other half is present. So this is the ruptured other half, and this is the protracted proximal portion of the ruptured bicep tendon. So this is obviously the humerus and the glenoid cavity and the acromion, and there is also this rupture of the subacromial ligament. So, but let's just focus on this for the proximal bicep, but there is also a rupture of the subscapularis here. So now we will talk about avascular necrosis. So avascular necrosis is actually death, the ultimate death of a tissue because of, or a bone in this case, or because of the cessation of nutrients and blood to that area. So this is stage 1, or there is, we can see the nutrient artery is what supplies the bone with nutrients and blood supply, right? So if there is any disruption in the supply of the nutrient artery, there is a resultant necrosis, which is known as avascular necrosis. So so this humeral head here is there are visible changes here. So this is stage 1, and when we will talk about all the stages, then we'll talk about how each stage is different. So this is stage 1, and this is stage 2. So like I said, there is osteoblastic activity, then there is a decrease in the bone density in that area. And how it appears, so there is this dark appearance here, or the hypo appearance on the MRI. Then this is an X-ray showing that this is more like an opaque presentation here. So this is because of the increase in osteoclastic activity. There is increase in ostium of the bone for a little while. So first is that there is increase in osteoblastic activity. There is increase in the bone formation cells to the site where there is decrease in blood supply, and there is the tissues are dying. So this is not happening overnight. It's not like the nutrient artery is damaged and overnight there will be the entire head of my humerus is going to disappear in thin air. That's not how it goes. So it's a long process, but eventually, because of vascular necrosis, the entire bone head can disappear if not treated on time. And obviously for the treatment of this will be surgery to establish a blood supply to the bone is the only way you can cure it. So then we have this stage 3. So then we have this osteoclastic activity starting at stage 3. There is absorption of bone in stage 3. So here, so what happens is this is happening in a cycle. So the osteoblastic activity happened first, but then it was replaced by osteoclastic activity. The area right behind it, there is increase in osteoblastic, which will be replaced by osteoclastic. So this osteoclastic activity is what the cycle will progress going down the bone, and eventually, if not treated, the entire bone can disappear. So that is how the avascular necrosis actually takes place. So this is bone formation and accelerated bone resorption, reabsorption, which is known as avascular necrosis. And the only way to cure it is to establish another way for the bone to get its nutrients and blood supply. So like I said, so this is a progressing phenomenon which will continue to dissolve the entire bone progressively, but this is a long process, and it is very painful as well. So this is very painful process, and it will be very hard for the patient to move even their limbs at this position or in this stage of the disease. So any movement will accelerate this or make it very painful for the patient, because obviously there is increased inflammatory process here, and inflammation will result in a lot of pain. So all the nerves will be hyperactive close to this region here. So lastly, we're going to talk about the soft tissue masses. So soft tissue masses, like I said, can be ossification of the tendon, muscles, ligaments, or they can be cancerous, they can be lipomas, but mostly the soft tissue masses are lipomas. So soft tissue masses with ossification in the upper arm is visible here. This is an X-ray of the arm. This is the humeral shaft, and then again, this is an abnormal structure right here. So as we can see, this is not normal. So this is a 3-month-old baby. As we can see, the ossification is not complete. Very tiny bones. So this is a baby of 3 months, and there is a soft tissue mass right here, and these are the margins. The entire region is a soft tissue mass. So this is how soft tissue masses appear on radiographs. So this is the acromioclavicular joint, and here it's not necessary for the joint surfaces to be like this if there is any degenerative process. They can be like this as well. So the cartilage is present between these upper surfaces of let's suppose this is the superior surface of clavicle and this is the superior surface of my acromion, and if the cartilage is present between the superior surfaces, it can be like this, but the inferior portion but in the inferior portion the cartilage has degenerated, or for some reason, or because of the excessive activity or friction. So this can also be the presentation of the degenerative joint, the degenerative arthritis. So there is increased sclerosis here and here, and the inferior surface is obviously there is a decrease in joint surface. And what happens because of joint surfaces constantly in contact with one another, obviously there will be bony spurs that'll form, either because of this the bone that is going to detach from here, the bony fragments, or because of the ossification of nearby structures which are constantly being impinged or stressed. So like we discussed in another lecture as well, so Greshey view is a special view to visualize the glenohumeral joint surface. So to prevent any overlapping of the glenohumeral surface, so we have this Greshey view, or some people call it Greshey view. So in this Greshey view, what happens is that we kind of have a 45-degree angle, and the bucky is behind, and and at this angle when my X-ray, when my shoulder will be X-rayed at this angle, then it will give a Greshey view, or the Greshey view, which is going to let us visualize the glenohumeral joint better. So in this Greshey view, what is to focus is not this glenohumeral joint, but this here, right here, is the calcification of distal supraspinatus tendon. So it can be supraspinatus tendon, which is passing right here. So the calcification, like I said, what happens is that continuous impingement will result in the calcification, which we have discussed previously as well. So this is the calcification of supraspinatus tendon. All of these four muscles attached to the greater tubercle of the humerus. So this is supraspinatus tendon calcification here, and this is the greater tubercle. So this is the root of it's actually like this. So this is the root of the supraspinatus tendon. It comes from the posterior surface, so its origin is from scapula, and its insertion is the greater tubercle of humerus. So then we have glenohumeral joint osteoarthritis again. So what happens is there is joint space narrowing, there is sclerosis, there is osteophyte formation. This is probably because of this this fragment constantly in friction, or there is this fragment that is probably dislodged from this surface here, and then it has ossified further, and this is a marginal osteophyte, as we call it, of the humeral head. There can be marginal osteophytes here as well, or here as well. These are the common sites because obviously that is where most of the friction will result because of the movement. Again, we have another Greshey view. So here we can, as we can see, like I said, the osteophyte formation can be commonly seen here and here. So this is a sclerotic bone formation, or sclerosis of the bone here. So yeah, this is a sclerotic bone present here. So we can also call it osteophyte formation, but we have to say there was increased sclerosis. So this is like we said, the supraspinatus is attached to the greater tubercle, and this is the tendon here, and this is the space. There is a complete rupture, and both the parts of the tendon have been retracted to their origin site or their insertion site. So this is the proximal supraspinatus tendon, and this is the distal supraspinatus tendon. So that is it for today. We discussed the chronic conditions of the shoulder in detail. We saw how they appear on radiographs. We discussed many conditions starting from the shoulder impingement, and we discussed how different joints of the shoulder complex are affected by the degenerative joint disease or osteoarthritis. We also talked about how if there is a rupture of bicep tendon, how it appears. We also talked about if the rotator cuff tendons are ruptured, how the shaft presents. We talked about the translation as well. We talked about all the radiographical interpretations of all these diseases, and I hope I made it interesting for you. And to watch more videos on different topics, please visit sqadia.com. That is it for today. Thank you for watching.